Has anybody read this guideline? Yeah, no one? I didn't yet. Okay, no problem. I'm just asking that, of course, we are going to discuss in depth. But moreover, it's a good idea that if you guys have read it once, so it is going to give you, the kind of good, the thing that you are going to learn it in a better way. Otherwise, I will try to summarize it. I will try to, give the gist of this guideline, what is new in this from the previous one. Because if they are changing in 2024 since 2015, it means they must have thought something, and now they really want us to, they know all of them, all of the changes, right? So let me. Okay, brilliant. So, guys, welcome on behalf of Medicorex. I'm sure you guys know me. I'm Dr. Zaib Qureshi, one of the mentor, in fact, one of the senior mentor in the online world for this MRCOG, MRCPI, and the FCPS, the groups as well. So I hope we are going to study this guideline in particular today in a proper way. That of course by the end of this session you will be able to solve your questions. Okay, my aim is going to summarize this, the guideline in such a way that at least it will be the later on you will just give it a read and you will have a thorough knowledge about it. Okay, so this is chickenpox in pregnancy. The organism which is involved in this chickenpox is Varicella zoster. The first edition of this guideline was in January 2015, and later on it recently got, the updated, in fact, last week. Okay, so we are going to cover, the many of the things out of them. Just before we start our discussion, in fact, formal discussion, let me just ask you, how many of you guys have started studying for MRCOG Part 2? And how do you find it? Because I think 2 weeks ago we have had a part two orientation session as well, where we have discussed the all aspects of MRCOG Part 2, how to discuss, how to, prepare and how to ace this exam, isn't it? So how many of you guys have started? I know many of you personally, but I would, appreciate if any of you guys can give me an idea that if you guys are facing any kind of trouble in preparing this MRCOG Part 2. Anyone? Just open your mic and just talk to me. Mariam, we start, but still, yes. It is yes, 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 yes. I agree. I agree. I agree with the fact that the course is very extensive because curriculum is like never ending, and you will just finish one thing, and the very next day you will have another thing, right? So sometimes what happens is that yes, you start studying and you just get lost in the one of the guideline. Like for this, we have been reading this chickenpox guideline since we have opened our eyes in this, the MRCOG world. But see, like 1.5, I think last week, the update has come, right? So yes, many at times it looks, the difficult, it looks, the very overwhelming, but I would suggest group studies is always better. You get to study and you are going to be in a the good shape later on. Yes, Mariam, I will be talking about it. Definitely, definitely, I will be talking about my, the course. So first we will discuss this, the guideline in depth, and later on we will talk about it. Me and Mehvish, we both are working day and night to just, they give our best knowledge to our students, okay? Be it part one, part two, or, the any other FCPS or MRCPI. Paid courses just give you the extra push, okay? So me and Mehvish, we both are working. I'm sure you guys know us very well by now. So we are working hard to just, the give you guys time to just to guide you guys as well, that at least you guys, they be on track. But of course, the paid courses just give you another, the push, another boost, that you are going to be in, the right frame of what you can say, the schedule and mind to go, because of course then you will get another, the extra, the kind of care. Okay. Um, thank you, Mariam. Thank you. Inshallah, I will try to give you all, the tips and tricks that how to pass this exam. So don't worry about it. I know you are very, the overwhelmed by the curriculum and all. So we will be talking about it. So let's first discuss this chickenpox in pregnancy. So let me just ask a basic questions from all of you that this is a virus, right? So which class does it belong to? RNA virus or DNA virus? You guys have just DNA. Okay, DNA. All right. DNA, double-stranded DNA, right? Double-stranded DNA. Very good. So this is a complete answer that it does belong to double-stranded DNA virus class. All right. Brilliant. So it's a DNA virus of the herpes family. So which class of the herpes family is it? We have got, the plenty of herpes family, isn't it? 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, we all know that herpes simplex, virus 1, virus 2. So which class is it? Herpes zoster, yeah, exactly. So it does belong to herpes family that is highly contagious and transmitted by respiratory droplets and by direct personal contact with the vesical fluid or indirectly via fomites like skin cells, hairs, clothing, and bedding. So you can see that if somebody who is having this herpes, the virus, so he or she is going to be highly contagious. So we need to be, the extra careful. Yes, herpes virus 3. Okay. So it's going to be highly contagious, right? So there is going to be a primary infection and a latent infection. Primary infection is termed as what? Chickenpox, okay? A primary varicella zoster virus infection. And the latent infection is termed as what? Hmm? Latent infection is
Shingles.
termed shingles. Brilliant. Okay. Latent infection is going to be termed as shingles. All right. So primary infection is characterized by, because primary is always going to be acute. And the acute symptoms are fever, malaise, pruritic rash that develops into crops of maculopapules, which become vesicular and then later on crust over before healing. Many of us, in fact, and the almost more than 90% of the individuals over 15 years of the age in England and Wales are seropositive for immunoglobulins. It means that they may have this acquired this herpes zoster virus at any point in their life. Okay, how many of you have had this herpes, chickenpox? I had it. Yes, sweetheart, they will ask you because you are going for January 2025 exam. So, of course, they are going to ask this one. Okay? Because, I mean, you have 5 months now, right? You have 5 months for January exam. So, yes, there are high chances that they are going to ask you from this. All right? So, incubation period for the primary infection is going to be between 1 to 3 weeks. And the disease, what is incubation period? Basically, what is incubation period? And which one is going to be dangerous? Incubation period or the full blown virus later on? Hmm?
Incubation period is more dangerous.
Mhm. Okay. For this,
Mom,
basically, yes.
sorry, you mean about definition?
Yeah. What is incubation period, first of all?
In- Incubation period is a period between entering the virus
Mhm.
and starting sign and symptoms.
Of these symptoms. Very good. Okay. So this is going to be the incubation period. Yes. So incubation period is going to be from 1 to, the 3 weeks. Okay. And the disease is infectious 48 hours before the rash appears and continues to be infectious until the vesical crust over. This is our exam question. They usually ask you when is the most likely or the say the highest, the point where this disease is going to be highly infectious. So this disease is going to be highly infectious 48 hours before the rash appears and continues to be infectious until the vesical crust over. So what we need to be, the kind of afraid of incubation period, because fever, malaise, pruritic rash, if it is coming, and then of course there are going to be crops of maculopapules. I'm sure you guys must have seen, the chicken pox, that it comes like this, right? It will comes like this, and later on, there are going to be confluences, multiple confluences of these vesicles, right? And almost all these vesicles have fluid, and that fluid is going to be contagious as well. So that's why it is termed as highly contagious. Okay, fever, malaise, pruritic rash, both things. So, chickenpox or primary varicella zoster is a common childhood disease that usually causes a mild infection. And more than 90% of the individuals over 15 years of the age in England and Wales are seropositive for varicella zoster virus immunoglobulin G antibody. Another exam question. Okay. So, contact with the chickenpox is common in pregnancy. Why in pregnancy? Because pregnancy itself is what? Immunosuppressive state, isn't it? Number one, immunosuppressive state. The young individuals, young children, of course, immunity is not that well developed in them. So it is very much, the important and prudent that in pregnancy we get to see this primary varicella zoster virus. And being a clinician, being a doctor, we should have to the pick it and treat it immediately, because it can complicate later on as well to the mother and to the unborn baby, and later on to the neonate as well. Okay, this is another exam question, that how much does it complicate in the pregnancy. So the incidence is for about 3 in every 1,000 women. See, you know, it is fairly common, right? So women from tropical and subtropical areas are more likely to be seronegative for varicella zoster IgG, and are therefore more susceptible to the development of chickenpox in pregnancy. Okay, the tropical and the subtropical or African countries where varicella zoster virus is not that prevalent. So in those areas, it is going to be negative. So this is also one of the exam question in which they are going to ask you that you are going to see a woman who is coming from any tropical country, okay, or they may name any country as well. All right. So then they are going to ask you that she is coming with such complaints. How are you going to manage this lady later on? Okay, so if they are going to be seronegative, then we have to be more, the careful for, providing them for a good care. So after primary infection, the virus remains dormant in sensory nerve root ganglia, but can be reactivated to cause a vesicular erythematous skin rash in a dermatomal distribution known as herpes zoster or shingles. Okay, so primary infection is going to be, the primary varicella zoster. Okay, primary varicella zoster virus infection. Secondary is going to be shingles, or the full-blown herpes zoster, and that usually is going to be in the nerve root. Okay, nerve dermatomes. Usually it happens on the back. Okay, back, or the side of the the abdominal wall, lateral side of the abdominal wall, or you can say, the all dermatomes. So usually it activates in those dermatomes, and that is going to be so painful later on, that infection. I have seen so many, the patients around. So the risk of acquiring infection from an immunocompetent individual with herpes zoster in non-exposed sites, such as thoracolumbar, is remote but can occur. However, disseminated zoster or exposed zoster, such as ophthalmic, because eyes are exposed to the external environment, isn't it? So, it in any individual or localized zoster in an immunosuppressed patient should be considered to be infectious, as the viral shedding may be greater. For example, any woman or any person who is having HIV, the most immunocompromised state. So, in that scenario, this ophthalmic varicella zoster can also disseminate quite quickly. Okay, so that's why. So the few things you need to be, the thinking of all the time. Any woman who is presenting with fever, malaise, rash, this varicella zoster is going to be your topmost, the differentials. Okay, then you are going to look at. All right. So after seeing the patient, you are going to counsel them that it is going to be highly contagious. Okay. So, limit your, the, what you can say, that mobility or whatever. Okay. So they are going to be, kind of, what you can say, isolated for 1 week, basically. till the the all these the psychopapular rashes will crust over, because that is going to be the highly contagious point. Plus, don't get exposed to their eyes, their the sneezing, their the respiratory droplets. So as long as they will get the spread, so any person who will come into contact will get this varicella zoster. So how do you prevent? Very important for any woman. So basically, any non-pregnant individual who is not sure of any, the varicella or the chickenpox in the childhood, all right, or any woman who does not show any kind of immunity in the pre-pregnancy or the pregnancy period, so we can give them, the vaccine. Okay, so varicella vaccination for pre-pregnancy or postpartum is an option that should be considered for women who are found to be seronegative for varicella zoster virus immunoglobulin G. Immunoglobulin G always comes when immunity develops. Immunoglobulin IgG-M is always going to be, M is for I am present, means this is going to be the acute infection. And G, when it will turn into any dormant state or when it will give the immunity. While universal serological antenatal testing is not recommended in the UK, seronegative women identified in pregnancy could be offered postpartum immunization. So that's why in history we always ask that, for example, if they are coming from any susceptible areas, or if we think that they might be negative for this and they are presenting with fever, malaise, and the rash, so in those women, it's the highly recommended that at least inquire and then they send the booking blood sample for IgG. If IgG is not there, so it means now we have to prevent them from further infection, from further exposure, and in the postpartum phase we have to offer them vaccination. So women who are vaccinated postpartum can be reassured that it is safe to breastfeed. The incidence of primary infection in the general population has fallen by over 80%, and the mortality related to the condition has decreased by two-thirds after the immunity. And how long does this immunity stays? Immunity is from the vaccine persists for up to 20 years. And immunity after the virus itself occurs for the lifelong, because every the virus who gives us long life immunity, it means we are going to be protected until and unless any unusual state arises or unusual circumstances happens. So two varicella vaccines are licensed for the use in the UK for the prevention of chickenpox. Number one is the Varivax, and the second is Verilrix. Okay, both are live attenuated vaccine administered two separate doses 4 to 8 weeks apart. And because they give rise to the somewhat of the the live what you can say the reaction. So in this we need the contraception as well for at least 4 weeks. So we will give two doses at least 4 weeks apart, and then after that we will advise the woman to have contraception for 4 weeks. So if the woman of the reproductive age is vaccinated, she should be advised to avoid pregnancy for 4 weeks after completing the two doses vaccine schedule, and to avoid contact with a susceptible pregnant woman should a post-vaccination rash occur. Because the mild, the illness can occur after vaccine as well, because it is a live attenuated vaccine. So transmission of the vaccine virus is rare. Despite it being a live attenuated virus, inadvertent exposures to the vaccine in pregnancy have been reported to register. Plus, there have not been any case of varicella, the fetal varicella syndrome, and no increase in the risk of fetal abnormality above the background risk. So it means vaccines are quite safe to be given, and it is very much recommended that anyone who is not exposed, the history is not confirmed that she has been exposed to this varicella in the childhood, we will send the booking sample, serum booking sample for IgG. If IgG is negative, postpartum we will give them two vaccines 4 weeks apart, and after two doses we will ask them to have the additional contraception for 4 weeks. Clear so far? Clear, everyone? Okay, brilliant. Okay, great. because we will go step by step. So it will be easy to understand. Okay, then now another question arises. Can varicella be prevented in the pregnant woman at her initial antenatal visit? So what you need to do is that first of all, you will take a detailed history, right? You will take a detailed history. A previous chickenpox, history of chickenpox infection had a 97.9 to 99.7% positive predictive value for the presence of serum varicella antibodies in women booking for antenatal care in the USA. However, in a study of British healthcare workers, 95% those who reported previous chickenpox infection had antibodies as well. Individuals born and raised in tropical climates are less likely to be immune. It may be appropriate to undertake serum screening routinely in this group of the women. If seronegativity is identified, postpartum vaccine could be considered. You know, so women booking for antenatal care should be asked about previous chickenpox, shingles infection, or varicella vaccination. This is updated 2024 guideline. Okay, so earlier they used to assume, but now they say that you have to be, sure of that whether they have been exposed or whether they have had vaccination. So it will be written in the history notes. Then another question arises, can varicella infection be prevented in the pregnant woman who gives a history of contact with the chickenpox or shingles? The answer is yes. First of all, how are you going to acquire? You are going to take a careful history at booking. If unexposed or uncertain, or come from a tropical countries, confirm through booking bloods, check for immunity or exposure. Okay, this is one group. Second group is if the pregnant woman is not immune to varicella and she has had a significant exposure, she should be offered post-exposure prophylaxis. We call it as PEP. Okay, stop here and just tell me, is this new or is this old thing? Because PEP
New.
we
This is new.
always, exactly, PEP we always used to study for which virus? HIV. Okay, so we used to study this post-exposure prophylaxis for only HIV, but now you can see that they are offering this PEP for varicella zoster virus infection as well. Okay, so this is pretty new for the us MRCOG candidates. So what will come in terms of PEP? So PEP is going to be oral antiviral therapy, that is acyclovir or valacyclovir is recommended as the first choice for PEP by the UK HSA. Okay, so it should be given from day 7 to 14 days post exposure. So we are going to be having, talking this about acyclovir and valacyclovir. This is one group. Second group is when there is a contraindication or adverse effect to antivirals, B-Zig may be considered as PEP. Stop here and just think that earlier we used to give these immunoglobulins as a treatment, isn't it? But now we are offering them as a PEP as well. But to which group? A group where this antiviral is contraindicated or shows some kind of adverse effect. Okay, so now keep it in your mind that acyclovir, valacyclovir, and VZIG can also be the PEP as well, post-exposure prophylaxis. So when do you give VZIG? Now what you need to remember as exam candidate is that oral antivirals are going to be given from day 7 to 14 days post-exposure. However, this VZIG is effective when given up to 10 days after contact. In the case of continuous exposure, this is defined as 10 days from the appearance of the rash in the index case. Index mean in the current case, where a woman has developed this varicella infection. Okay, clear so far? So this is going to be for the group of the women who just have had a contact with the chickenpox, means primary infection, or even shingles as well. So in these, if a woman is getting exposed, so we have to offer them PEP, okay, post-exposure prophylaxis. Okay, now what about history? History is not going to be as simple as it looks. Okay, so the history must be confirmed with particular respect to the type of varicella zoster infection, the timing of infection, the closeness, and the duration of contact. What does it mean by the type of varicella infection? So chickenpox is infectious for 24 hours before the appearance of rash and the duration of the illness while the skin lesions are active. It ceases to be infectious when the lesions have crusted over. I'm sure you must have seen, the any varicella patient, or you must have acquired it, varicella in the childhood as well. So I have had this chicken pox, and I still remember that was so terrible, so painful. And I have had, the high grade fever, and I was like isolated for good, 7 to 10 days. And it was such a terrible phase, but what to do? Okay. So, the it is not going to be infectious once the lesions have crusted over. And once they crust over, there is going to be intense itching on the body as well. And if you do itch, it will leave the marks. So that's why, they always say that, don't itch, don't do, the a lot of scratching or something, and even touch it, because it will leave the scar marks over there, on the body, round, round, round. So the herpes zoster, shingles, also poses a risk if it is disseminated or it occurs in an exposed area, for example, eye, or in an immunocompromised individual where viral shedding may be greater. The risk of infection following contact with the herpes zoster that is not in an exposed area, thoracolumbar, it can also be there. So after exposure, the immunity of the shingles might be lifelong. Mariam, if that is your answer, right? So the next question arises, the timing of the exposure. Significant exposure can be continuous, e.g., for example, in the household or in the nursery. More than one exposure, for example, in the household visitor. Single exposure to a case of chickenpox during the infectious periods described above, or a single exposure to the infectious shingles as described above. Nursery means, the where there are going to be multiple, the small kids. Of course, they are so much susceptible to get, this, the any viral infection, right? Because immunity is not that developed. So this is going to be your timing of exposure. Then closeness and duration of the contact. We always ask significant contact. What is significant contact? Significant contact is defined as a contact in the same room for 15 minutes or more, face-to-face contact, or contact in the setting of a large open vault. This is significant contact. The susceptibility of the woman should then be determined by eliciting a past history of chickenpox or shingles or varicella vaccination. If there is a definite past history of chickenpox or shingles, or she has received 2 doses of varicella vaccine, it is reasonable to assume that she is immune to varicella infection. Plus, this is third category, where women's immunity to the chickenpox is unknown, or if there is any doubt about the previous infection, vaccination, or if there is no previous history of chickenpox or shingles. So in that scenario, you will send serum should be tested for varicella zoster virus, IgG. This can usually be performed within 24 to 48 hours and often within a few hours if the laboratory can access serum stored from an antenatal booking blood sample. Another exam question. And this usually comes in exam. That, the immunity is not known. How are you going to confirm that this woman has had this, the varicella in the past? So at least 80% of the women tested will have IgG and can be reassured. But PEP should be offered if IgG is negative, or if it is less than 100 milli-international unit per ml. So this is also an addition. Earlier, we don't used to talk in terms of, the antibody levels as well. Okay. But from now on, you need to understand this as well. That how are you going to offer? If they are negative, you will offer PEP. Although, the IgG is negative or their level is less than 100 milli international unit per ml, you are going to offer them PEP as well. Of note, if the pregnant woman is immunosuppressed for a reason other than pregnancy, a history of previous infection or vaccination may not be sufficient evidence of the immunity, and serum should be tested for the varicella zoster virus IgG, and PEP should be offered if it is negative or if it is less than 150 milli international unit per ml. Okay, in terms of previous infection, vaccination, so in that scenario, you are going to offer them, right? Now, another question arises. If a pregnant woman is not immune to varicella and has had significant exposure to chickenpox or shingles, she should be offered post-exposure prophylaxis. Now we will talk about PEP as well. So in terms of PEP, we will have the couple of the antivirals. Which antiviral and which route? This is also important. So first, we will offer them oral antiviral therapy, that is acyclovir or valacyclovir. Is recommended as the first choice for PEP by the UKHSA. It should be given from day 7 to day 14 post-exposure. So what is acyclovir? Acyclovir is a synthetic nucleoside analog that inhibits replication of zoster virus. Acyclovir treatment is delayed until 7 days post-exposure because it was shown to be less effective in preventing clinical chickenpox in healthy children when treatment was started immediately. The dose is 800 milligram 4 times daily. The dose of valacyclovir is 1000 milligram 3 times daily. Valacyclovir is a prodrug of acyclovir with better bioavailability and adverse effect profile with less daily doses required. So acyclovir is recommended. Acyclovir is recommended because there is more data regarding safety in pregnancy compared to valacyclovir. So don't choose valacyclovir at first place in exam. If acyclovir is in the option, you will choose acyclovir. Okay. So adverse effects of acyclovir are going to be headaches, dizziness, nausea, vomiting, diarrhea, like every other the drug. The dose may need to be reduced if there is impaired renal function and the drug may not be absorbed adequately when there is active IBD. New addition. Okay. So if a woman is having active IBD, so in that scenario, we need to reduce the dose. Okay. Impaired renal function or in the IBD patients. Both drugs are not licensed. This is another important thing. Both drugs are not licensed for PEP for chickenpox or in the pregnancy, but the evidence for their use in this setting has been considered and recommended by PHE and UKHSA expert working group. So this line should be told in the counseling session. So this you will learn when you will enter into your part 3 exam. Okay. However, you need to know that even though they are not licensed, but yes, they are widely being used in pregnancy. Okay, because of the the safety profile and all right. But when you are going to talk in terms of to the patient in part 3, so this line should be told to them that although this is not licensed to they give in the pregnancy, but data has been suggested that it is relatively safe. Okay, or you can say it is pretty safe. Okay, then second setting occurs that when there is a contraindication or adverse effect to antiviral, then what you are going to do, you are going to give VZIG, may be considered as PEP. Okay, now what I can think of that how a question can come is they can ask you about the PEP, okay, and then they can give you the choices, for example, in terms of scenario, and then they can ask you. So what you need to understand is that acyclovir again is going to be your drug of choice for PEP, followed by valacyclovir. If both are not there, then only you can, they pick this basic, okay, because the word is considered. All right. So what is basic? So varicella zoster immunoglobulin is a human immunoglobulin product manufactured from the plasma of the non-UK donors with high VZV antibody titers. Issues to pregnant women may be restricted when supplies are limited, and hence clinicians are advised to establish the availability of VZIG before offering it to the pregnant individual. In this context, when you are going to offer, in this context mean in terms of PEP. So PEP you are going to offer if IgG is negative or if it is less than 100 milli international unit in immunocompetent pregnant woman and less than 150 in immunocompromised pregnant women. I hope it will clear the ambiguity of less than 100 and less than 150 now. Right? Clear, everyone? In immunocompetent individual, less than 100, varicella zoster virus IgG is negative and titer is also less. But immunocompromised, even you will take the less than 150. Okay? So these cutoffs should also be in your mind. So when you are going to offer this, VZIG, you are going to offer this VZIG as soon as possible or at the very latest within 10 days of the exposure. In the case of continuous household exposure, within 10 days of the appearance of the rash in the index case. So you can simply say within 10 days of the exposure. The rationale for administration of VZIG is that it may prevent or attenuate chickenpox in non-immune individuals and that it may reduce the risk of development of fetal varicella syndrome. In an observational study of 212 seronegative women who received an appropriate dose of VZIG, either intramuscular or intravenous, within 10 days of significant exposure to the chickenpox, half of the women developed either a normal or an attenuated form of the chickenpox, and a further 5% have had a subclinical infection. Okay, but nonetheless, it is considered to be safe. Then, in the recent PHE UK HSA follow-up study demonstrated no significant difference in the rate of chickenpox when acyclovir and VZIG were used as a PEP. There was, however, a difference in adverse effect. 10% of the women that received VZIG reporting pain at the injection site and no reported adverse effect in the acyclovir group. Because most of the time, acyclovir is oral and VZIG is going to be either intramuscular or intravenous. So there can be pain at the injection site. That is, the quite understandable. If chickenpox doesn't develop in a seronegative woman, pregnant woman, and there is a further exposure, that can happen, right? Pregnancy is of a 9 months duration. So if at any point in time a further exposure to the chickenpox during the pregnancy happens, testing for VZIG should be repeated regardless of whether or not PEP was prescribed after the initial exposure. I think this can also be one of the exam questions. Okay, so we would go for varicella zoster virus immunoglobulin G. Okay. So if seroconversion has not occurred, a second course of antiviral can be prescribed after the exposure of 7 days. If VZIG is used for PEP, it can be repeated in the repeat exposures occurs 3 weeks or more after the last dose. Another, the good, the concept. If the VZIG has been used for PEP, and then there is another repeat exposure, but at least if there was a time more than 3 weeks, then we can repeat VZIG as well. Susceptible women who have had a contact with the chickenpox or shingles, regardless of whether or not they have received PEP, should be asked to notify their doctor or midwife early if a rash develops. So despite the benefit of PEP in preventing or attenuating the disease, pregnant women may still become seriously ill. Reason being because pregnancy is a immunosuppressive state. Clear so far, guys, for PEP? Any question? I'm going a bit slow, so at least everybody will understand it properly.
So, Dr. Zaib, now in pre-pregnancy counseling, we will ask about this vaccination for varicella also.
Yes, not only vaccination, Dr. Atia, but also the exposure as well. Okay, history.
Yes, yeah.
Yes, history,
Okay.
childhood history, plus you will ask for vaccination as well, both. Okay.
Okay.
Good job, Vaishnavi. Thank you. All right. Okay, now we will talk about of course, it's an infection, right? So there can be maternal risk and there can be fetal risk as well. So always remember that when you study any topic, so always divide your risk into 2 parts. Never forget baby, never forget, the mother at the same time. So what are the maternal the risk? Pneumonia can occur up to 10 to 14% of cases. It can be more severe at the later gestational ages due to the effect of gravid uterus on the respiratory function. Patient can have hepatitis, encephalitis. Rarely it may result in death. So the more recent cases report mortality rate of 0 to 14% with improvements attributed to antiviral therapy and improved intensive care. So I've been reading this guideline. So it said that, if a woman has had, this pneumonia, that can end up in taking the life of the woman. Okay. So that's why early institution of the antiviral therapy is prudent for the prevention of such grave consequences. For the fetus, of course, we will say that spontaneous miscarriages does not appear to be increased if the chickenpox occurs in the first trimester. Okay, good thing. But what about fetal varicella syndrome? Fetal varicella syndrome is less than 1%. So it can be characterized by one or more of the following: skin scarring in the dermatomal distribution, eye defects, microphthalmia, chororetinitis, cataract, hypoplasia of the limbs, and neurological abnormalities like microcephaly, cortical atrophy, mental retardation, or dysfunction of the bowel and bladder sphincters. It doesn't occur at the time of initial fetal infection, but results from a subsequent herpes zoster reactivation in utero and only occurs in a minority of the infected fetuses. So maybe, the first infection might not result in fetal varicella as such, but if there is subsequent herpes zoster reactivation in utero, it will result into such, the fetal varicella syndrome, less than 1%. So then question arises, how are you going to take care of the woman who develops chickenpox? So pregnant women who develop chickenpox rash should immediately contact, first of all, their GP. And women should avoid contact with the potentially susceptible individual, for example, other pregnant women, neonates, until the lesions have crusted over, and that is usually about 5 days after the onset of rash. Plus, you will give them symptomatic treatment for temperature, for their sneezing, for their, anything, okay? Oral hygiene, the body hygiene to prevent secondary bacterial infection of the lesions. You will start oral acyclovir should be prescribed for the pregnant women with chickenpox if they present within 24 hours of the onset of rash, and if they are 20 plus weeks of the gestation or beyond. So here we will stop and we will just, try to absorb it. Symptomatic treatment plus specific treatment, right? Symptomatic treatment is going to be paracetamol, okay? The local menthol cream or anything, okay? Hygiene, oral hygiene care, antihistamine just for the, not to itch or not to scratch the lesions, all right? And then comes the specific lesions. So if the woman is more than or equal to 20 weeks, okay, or if they present within 24 hours, so we will start oral acyclovir. So use of acyclovir before 20 plus weeks should also be considered. Means less than 20 weeks can also be considered. Acyclovir and valacyclovir are not licensed to be used in pregnancy. However, it can be prescribed in the best interest of the woman on the basis of available evidences, consultation, and after the consultation with her. So IV acyclovir should be given to all pregnant women with severe chickenpox. Okay. So severe chickenpox should be treated with IV acyclovir. VZIG has no therapeutic benefit. This is also one of the exam question. VZIG have no therapeutic benefit once chickenpox is developed and should therefore not be used in pregnant women who have developed chickenpox rash. Means when vesicles have crusted over, then we cannot give anything. Okay, so that's why it is very much important that we, ask if any woman who is coming with any, the viral sign and symptoms, okay, about the rash in particular. So if they are coming for within 24 hours, if the gestation age is more than 20 weeks, then yes, we can give them oral acyclovir. So the UK advisory group on the chickenpox recommend oral acyclovir for pregnant women with chickenpox if they present within 24 hours of the onset of rash and if they are more than 20 weeks of gestation. Okay. VZIG is recommended for post-exposure prophylaxis when acyclovir and valacyclovir are contraindicated. In that scenario, we will offer them, and they are intolerable because of the side effects, and it is the not appropriate for the patients with clinical chickenpox. We have a question. Kindly clear this. I am confused whether to start a cyclovir within 24 hours of rash appearance or delay it into the start. No, 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 no. There are two things. Again, I don't know your name, H, but one is PEP and the other is treatment. Why are you getting confused between two? Hmm? Treatment should be within 24 hours. Okay? PEP is what? Post-exposure prophylaxis. This is for such individuals who have been exposed by primary chickenpox or shingles. So in those, you have to give PEP. Got it? Hmm? Okay, got it? Okay, great. Right? So don't get confused. All right? So treatment, of course, we will offer for clinically evident chickenpox. And the PEP we will offer to the individual who have just been exposed with primary varicella or shingles. All right? Then question arises another. Should women be referred to hospital? Not every woman should be referred to hospital, but yes, certain women should be. All right. So first of all, if they develop any respiratory symptoms, severe, or any other deterioration in her condition, women who develop symptoms and signs of severe chickenpox should be referred to immediately to the hospital. A hospital assessment should be considered in a woman who is at high risk or severe or complicated chickenpox, even in the absence of concerning symptoms. The assessment needs to take place in an area where she will not come into contact with other pregnant individuals. Appropriate treatment should be decided in consultation with MDT, that includes an obstetrician, a fetal medicine specialist, a virologist, and a neonatologist. Women hospitalized with varicella should be nursed in isolation from babies, potentially susceptible pregnant women, or non-immune staff. Makes sense because it is highly contagious, isn't it? Then, what type of the patient should be in the hospital with ICU care? Okay, so ICU care can be provided to a woman who is having severe chickenpox symptoms, respiratory symptoms, neurological symptoms such as photophobia, seizure, drowsiness, hemorrhagic rash, or bleeding, or a dense rash with or without mucosal lesions are indicative of potentially life-threatening chickenpox. They should be immediately referred to hospital where ICU care can be provided. One scenario. Second scenario, we have just said that hospital referral. So the ideally, a woman who is the cigarette smoker, who has a chronic lung disease, or she is immunosuppressed, including those who have taken systemic steroids in the preceding 3 months or is in the second half of the pregnancy. So such women should have a hospital assessment as well, even in the absence of complications. Because even if we just think about these women, so we can always think of that, okay, they can get complication at any point in time in their pregnancy, isn't it? Because the later half of the pregnancy is also vulnerable phase, plus the one who smokes cigarettes will have the low immunity, low chronic lung disease, might not cope with the the new onset of respiratory symptoms. Okay, so in such women, they should have a thorough hospital assessment as well. Okay, so don't get confused between these two again. Okay, one is the woman who is having all these symptoms and she needs hospital assessment with where ICU care can be provided, and all these group of women where a hospital assessment is needed. Okay, clear everyone so far? Brilliant. Good job. Good job. Okay, brilliant, brilliant. Very good, very good. Thank you. Thank you so much, Vaishnavi. Thank you. Brilliant. All right. Now, what about timing and mode of delivery? Right? Because we are dealing with pregnant individual. So depending on the severity of the maternal condition, a respiratory physician and a ITU specialist may be involved in the peripartum care as well. Now, delivery during the viremic period while the chickenpox vesicles are active may be extremely hazardous. So delivery may precipitate maternal hemorrhage and or coagulopathy due to thrombocytopenia and hepatitis. So there is also high risk of, the varicella infection of the newborn with significant morbidity and mortality. So supportive treatment and IV acyclovir are therefore desirable, allowing resolution of the rash and also immune, the recovery and transfer of the protective antibodies from the mother to the fetus. So ideally, a minimum of 7 days should relapse between onset of the rash and delivery. Because in this, the 7 days, this immunity will be passed down to the baby. Otherwise, it is going to be dangerous. However, delivery may be required to facilitate assisted ventilation in case where varicella pneumonia is complicated by respiratory failure. Okay, so in this scenario, what we call it as iatrogenic birth. Okay, in which we are doing or delivering baby iatrogenically to save the woman life. For example, if she has developed this varicella pneumonia, so yes, in that scenario, we may deliver her early. Then what about anesthesia? So anesthesia in the patients with varicella zoster, there is no evidence available to inform decisions about the optimum method of anesthesia for women requiring delivery by cesarean section. General anesthesia may exacerbate the respiratory compromise with pneumonia. There is theoretical risk of transmitting the varicella zoster virus from skin lesions to the central nervous system via spinal anesthesia. As the dura is not punctured, epidural anesthesia may be safer than the spinal anesthesia. However, the larger needle is required for epidural, which carries the theoretical risk of transferring a greater viral load from skin to the epidural surface. Theoretical risk only. So a site free of cutaneous lesions should be chosen for needle placement. Okay, this is for a woman who is having active varicella zoster and she is just about to deliver. Okay, otherwise, if in first trimester varicella has occurred and now we have to deliver, so all these things are not going to come into the concentration. Okay, clear everyone? Okay, now question arises, another question, right? The woman who developed chickenpox in pregnancy should be referred to a fetal medicine specialist at 16 to 20 weeks or 5 weeks after the infection for discussion and detailed ultrasound examination. Right? We have just discussed the about the fetal varicella syndrome, which is less than 1%. Baby may have some eye problems, some limbs problem, so those can be detected at anomaly scan. Given that immunosynthesis has a strong negative predictive value but a poor positive predictive value in detecting fetal damage that cannot be detected by non-invasive methods, women who develop varicella during pregnancy should be counseled about the risk versus benefits of amniocentesis to detect varicella DNA by PCR. Again, amniocentesis should not be performed in the active lesions. So before the skin lesions have completely healed, we are not going to do any procedures. So prenatal diagnosis of fetal varicella is possible by scan when findings such as limb deformity, microcephaly, hydrocephalus, soft tissue calcification, and fetal growth restriction can be detected. A time lag of at least 5 weeks after the primary maternal infection is advised because ultrasound performed at 4 weeks has failed to detect the abnormalities. So we will take at least 5 weeks window period. Fetal MRI may provide additional information in cases where ultrasound has identified morphological abnormalities. So VZV DNA can be detected in amniotic fluid by PCR. The presence of DNA has a high sensitivity but a low specificity for the development of fetal varicella syndrome. So what about neonatal varicella? So neonatal varicella or varicella infection of the newborn, this is the new name, okay, according to this guideline, refers to varicella zoster infection in early neonatal period resulting from maternal infection near the time of delivery or immediately postpartum or from contact with the person other than the mother. other than the mother with chickenpox or shingles during this time. Interesting, isn't it? So the route of infection can be transplacental, ascending vaginal, or result from direct contact with the lesions during or after delivery. So if maternal infection occurs 1 to 4 weeks before delivery, up to 50% of the babies has infected and approximately 23% will develop clinical varicella. It can be an exam question. Despite high titers of passively required maternal antibody, severe chickenpox is most likely to occur if the infant is born within 7 days of onset of the mother's rash, or if the mother develops the rash up to 7 days after delivery. Okay, makes sense. For the babies born to mothers who have had a chickenpox within the period 7 days before to the 7 days after delivery, means 2 weeks, right? It is therefore vital that the neonate receives prophylaxis as soon as possible with VZIC, with or without acyclovir. There is no need to test in these circumstances because either way, there are high chances that this virus will transmit from mother to the baby. So what about breastfeeding? It's pretty safe if the mother wish to and well enough to do so. If there are active chickenpox lesions close to the nipple that should express milk from the affected breast until the lesions have crusted over, the expressed breast milk may be fed to the baby who is receiving treatment with the acyclovir or BZIC. Clear, everyone? Clear, everyone? Any questions so far?
So, Dr. Zaib, if this fetal varicella syndrome comes positive during amniocentesis, then we can advise this lady for termination of pregnancy about according
No. It is just less than 1%.
If it is diagnosed on amniocentesis or on ultrasound, baby has deformity. Then
I don't think so.
like
I don't think so. No.
microcephaly or
If it is microcephaly, then maybe yes. Okay. Then maybe yes.
Yes.
If it is a confirmed microcephaly, then yes, you can the counsel. But otherwise, nowhere in guideline it is written that you have to offer termination of pregnancy. Okay, because the incidence is very less than 1%.
Okay.
Yeah. But yes, if it is a confirmed the case of the case of microcephaly, then yes, maybe in that scenario you can offer. But again, be extremely careful because top the offer is the very very sensitive the point. So this is again the same thing. Okay, so I think this is going to be cleared again, that first of all the contact, clarify the significance of the contact, past history, three groups, right? Past history of the chickenpox or having had the vaccination. Second group is who is uncertain or no past history of chickenpox or woman from a tropical or subtropical country. And the third is, the woman who is coming with chickenpox. Initial contact should be done with the woman's GP. So in this group, what you will offer them? Booking blood samples for IgG antibodies. If IgG antibodies are present and more than 100, no action needed. Just reassure and return to normal antenatal care. If IgG is not present, but it is less than 100, more than 100 means immunity is there. Less than 100 means no immunity is there. So in that scenario, you will offer them, the PEP. Okay, give a acyclovir from day 7 to day 14 post-exposure. Dear H, I don't know your name, but I hope now it will clear your point further. So, or you may offer VZIC. Advise the woman that they are potentially infectious from day 8 to 28 days after contact. Discuss postpartum varicella immunization. Okay? All right, clear now? That women then avoid contact with potentially susceptible individuals, symptomatic treatment, and the hygiene should be advised. If the woman presents less than 24 hours and if she is more than or equal to 20 weeks, prescribed acyclovir. If the woman is less than 24 hours of the appearance of the rash and she is less than 20 weeks, you may consider acyclovir. Okay? Avoid delivery of the baby until at least 7 days since the rash appeared. If the the infection is severe, woman should be referred to hospital, right? or if the infection at less than 28 weeks of gestation, inform women, Dr. Atia, for you, inform women that infection at less than 28 weeks is associated with a small increase risk of fetal varicella syndrome. So in this scenario, you will refer to fetal varicella, you will refer to FMU, fetal medicine unit, at 16 to 20 weeks or 5 weeks after infection. And they may offer amniocentesis to detect varicella DNA. And if on, the any DNA is positive or any abnormality is positive, then yes, you may have, the multiple options. I think this is pretty, the easy and pretty clinical now. They have made, this PEP as well quite, the easy. That any woman who is coming with this and who is uncertain for the history of chickenpox and she has significant exposure. So yes, we have to give them the post-exposure prophylaxis. Clear, everyone? Yeah. Any question? Hmm? Very good, very good. So I hope it will help you when you will solve your question and when you will read it yourself. So you are not going to have any doubt, all right? Because this guideline is very important. So I really believe that, a couple of questions can come in exam. Mariam, are you there? Is it clear to you as well? Hmm? Anam, how are you? Abda, is it clear to you? Yegu, Farkhanda, Manikam, Dr. Sarvat, how are you? Is it clear to you? Very good.
Fine, ma'am. Thank you, ma'am.
Alhamdulillah, that's good, that's good. All right, so this is for Mariam. So we are going to start our course and, it is going to commence from 15th of September. And we are going to be having similarly like we have had, the class today. So 20 plus online sessions on all modules with extensive SBA and EMQ practice in close group, close to exam. I will be conducting talks workshop covering the important talk articles, not all, of course, we can't cover. So we have to choose the potential important one which can come in exam. Plus I will conduct exclusive EMQ workshop as well. Plus, the important exam like questions workshop as well. So altogether, all these things are going to be included in this. And, the anyone who wish to joins can, they contact me, Mehvish, or our team as well, or contact on our official WhatsApp group or WhatsApp number, or even, the page as well. So hopefully we will try to guide you properly that how to go about this exam. The session time, yes, sweetheart, because at present I'm in Pakistan, so the time is like 7 o'clock, right, at 2 p.m. GMT, because we have 5 hours difference. Okay, so 2 p.m. GMT means 7 o'clock, and if we will start our session, so it will end by like 10:30 p.m. So for Pakistani, Indian, and Bangladeshi candidate, it is the very late. Okay, so that's why I always choose a time where the candidates can come in class and can have a one-to-one interaction, because that really that makes things easy and understandable as well. Okay, inshallah, inshallah, no problem. I'm always there. Okay, I'm freely available. You guys can contact me. So just the dream it, believe it, build it, and go for it. There is no shortcut to success. Okay, you have to work hard. You have to work hard for every exam. So I mean, no, none of the exam is like a piece of cake. You have to work hard, you have to work smart. And for January exam, there is another the message in private that is time enough. Yes, it is very much enough. Nobody can study for years. Okay, if you will leave your January exam now, so you will have a July the exam, and that is going to be after like how many months, 10 months, 11 months maybe. Okay, so I don't think that it is a wise idea, because nobody can study for years and years, and this is such a cumbersome the routine, that read guideline every day, do questions every day, they do this rehearsal each and every day. So why not give your 100% in this 4.5 months, and yes, you are good to go. Shortcut. Shortcut is just this, that I name myself as Lubna. Okay. That is the only shortcut I can give you. So, the if I go at your place, then that is the only shortcut. And perhaps I don't know how I will perform in exam, but this way or that way, yes. So, guys, you just have to work hard. You just have to work hard, work smart, and daily, consistent, and persistent study is required for this exam. Okay? Because syllabus is never ending. You get to see so many things. You get to see so many, the new talk articles, new guidelines every day. So it's a good idea that you study on daily basis, isn't it? So I would suggest that, uh, my brain, at the moment, my brain is not that good. Oh, yes, maybe a couple of years ago, it was like, I mean, brilliant. But now, even I have to revise as well when I come to the session. And this is a good habit of a teacher as well, that, a teacher has to be up to date, because I always think that students are very much up to date. They study so, the good, that they might, they surpass their teachers. And I really, they love that. Okay. So, this is really going to be a good idea that, if you guys study, and if we do any mistake anywhere, do point out, that to us. So at least we will correct it as well. Okay. Because we are also human beings, and there is no harm in upgrading yourself at any point. Okay. So yes, inshallah, I will see you guys next week. Like as promised, that I will do another session on SGA guideline. So we will do a SGA guideline discussion. Okay, I will try to the ease things out for you guys, and I will be taking the time to time all these sessions. And of course, course is always there. Okay, and course will just give you a focused the kind of push. Otherwise, for free groups, you are always welcome. The study with us. Okay, me and Mehwish, we both are there to guide, to support, to the encourage, and to of course push you guys as well. All right. So anybody who wants to join me, please do join. I'll be so happy to the teach and coach, and to be a study partner with you till your part 3, inshallah. Thank you. Thank you so much. I will upload the recording once it is done, and I will notify all of you. So please read this guideline, not today, but with the schedule. However, do study on daily basis. Okay, with the given schedule. Even if something is left, do try to cover it, in your leisure time, or if you feel that the Sunday is off, then yes, you guys can. Because I think in September we have kept Sundays off, but from October you will not have even Sunday off as well. So cover as much as you can, all right? Because the days are approaching, the quite fast. So September, October, November, December, and 22nd you have your exam. So I think plenty of time, 5 months almost. So why waste, a single, the day from October, no holiday, okay? Till September you can enjoy. All right, because we have to cover a lot. All right, thank you so much, guys. Thank you so much. Thank you so much. Inshallah, I will see you guys next week with small for gestational age guideline. I will try to summarize it. I will try to emphasize important exam points as well, and we'll try to bring some questions as well. Okay, so we will do some question practice too from SGA, because I know many question cases because I'm teaching part 3 these days. So many question comes from the SGA guidelines as well. Okay, Adila, thank you. Thank you so much, Lubna, Amna, Saira, everyone. Okay, so inshallah, I will see you guys next week. Bye bye. Allah Hafiz.